7 o'clock. So, good morning, everyone. 10-10-2020, World Hospice Palliative Care Day 2020. And we are very proud that All India Institute of Medical Sciences is celebrating World Hospice and Palliative Care Day by discussing something very, very important. And for this, we have a guest speaker, Professor Arik. I would request our director, Professor Guleria, to introduce Professor Arik, and we will start his lecture. We have an esteemed panelist of 8 panelists from all over country. They are stalwarts in their areas. We will introduce them one by one with their questions. So, sir, please introduce Professor Arik. Good morning, sir.
Good morning. Thank you very much. First, let me congratulate the Department of Onco-Anesthesia and Palliative Care for celebrating the World Hospice and Palliative Care Day. And we have a very esteemed speaker today, Dr. Eric Karkor, who is going to be speaking to us today. He has received a PhD in philosophy and an MD from Yale University and trained in internal medicine at the Yale New Haven Hospital, and he completed his fellowship in general internal medicine and in internal medical ethics at the Harvard Medical School. Currently, he is associate professor of medicine and of global health and social medicine at Harvard Medical School, and he's also an attending physician in the division of palliative care and genetics at the Mass General Hospital, where he also directs the global palliative care program. For over 15 years, he has been providing training and technical assistance for ministries of health in major hospitals and colleagues in low and middle income countries across the world. Various countries he's been involved in, and he's helped these countries help in integrating palliative care into healthcare systems and healthcare education. He's also served as a medical officer for palliative care at WHO and has edited the WHO manual on integrating palliative care into primary healthcare, into pediatrics, and into responses to humanitarian crisis. He's also been in the Lancet Commission on Global Access to Palliative Care and a visiting associate professor at the University of Medicine and Pharmacy at the Ho Chi Minh in Vietnam. So he has, I think, a huge or vast experience as far as palliative care in developing world is concerned, and I would take this opportunity to really thank him and invite Dr. Eric to give his talk. Thank you very much.
Thank you, sir. So, Professor Arik.
Thank you for that very kind introduction. It's a great honor to be with you and to see many friends and colleagues and mentors online. Let's see. I'm going to try to share my screen. Okay, now how do I share my screen? Share. We just did it a moment ago. Okay. Okay. So good morning, and thank you for your very kind invitation. I'm very happy to be with you on World Hospice Palliative Care Day. And unfortunately, it's in the middle of many global problems, including the COVID-19 pandemic, which we had very severely here in Boston in April and May. And now it's coming back again. I know there's been a lot of difficulties in India. And I also know that the conditions that we have in Boston are very different from India. So I hope that much of what I say will be relevant, but I recognize that practices may be different. I always like to begin with a patient. And in this case, it's a patient in the ICU who has had respiratory failure and probably experienced a lot of dyspnea, shortness of breath, before endotracheal intubation. And now she is in the ICU. She's not able to have visits from family. And even her interactions with healthcare team are limited by their gowns and masks and face shields. So it's physically and emotionally and often also socially and spiritually very painful. There's a lot of suffering associated, as you know well. As far as my disclosures, I don't receive any funding from any drug companies or medical equipment manufacturers or private industry. In the next 20 or so minutes, I'd like to talk about some of the medical and ethical principles of palliative care during the COVID-19 epidemic. Related to that are the crisis standards of care when resources are limited. And I'll also talk about infection control, symptom relief, and psychosocial support. There's very strong moral argument for palliative care in response to any public health crisis where there's inadequate resources for the number of patients. So for example, from the United Nations Office for Coordination of Humanitarian Affairs, there's an emphasis not only on saving lives, but also on alleviating suffering. And this is really the crux of the issue in integration of palliative care into responses to humanitarian crises and public health crises. There's been an emphasis on saving lives and much less so on alleviating suffering, despite the presence of this principle of alleviating suffering in the guidance documents. The principles of humanitarian action as propagated by the International Committee for the Red Cross, for example, and the International Federation of Red Cross and Red Crescent Societies are fourfold: humanity, neutrality, impartiality, and independence. And humanity is defined as human suffering must be addressed wherever it is found. So again, even in the principles of humanitarian medicine, there's an emphasis on prevention and relief of suffering, not only on saving lives. Most of you, I think, will be familiar with the World Health Assembly 2014 resolution on palliative care, where it states that it's an ethical duty of healthcare professionals to alleviate pain and suffering, and that palliative care is an ethical responsibility of health systems. And in addition, it emphasizes the imperative that essential medicines be accessible for palliative care, particularly morphine. And it states that efforts to prevent the diversion of narcotic drugs such as morphine should not result in inappropriate regulatory barriers to medical access to such medicines. Morphine must be accessible for all in need to relieve pain, and more often in the setting of COVID-19, it's for relief of dyspnea, and I'll come back to that. Of course, with appropriate rules and protections to minimize the risk of illegal use and diversion to illegal uses. Unfortunately, palliative care is not yet well integrated into humanitarian medicine. The Sphere Handbook, which is the most accepted handbook of humanitarian medicine, was revised in 2018. I was asked to write a section on palliative care, but what came out was not what I wrote. It really said that palliative care is only for end-of-life care, which is an old-fashioned idea. Maybe in the next version of the Sphere Handbook, it will be better. And one of the big problems is that moribund patients, patients who are not expected to survive, in the terminology of humanitarian medicine, they're called expectant patients, are often neglected. And also mental health services often are very inadequate. This slide shows a typical triage scheme that has been used in recent decades in response to humanitarian crises. The first category in red is for those patients who require immediate aggressive treatment if they are to survive. Survival is possible with immediate treatment. Second, in yellow, is those who are not in immediate danger of death, but will need treatment very soon and would be treated immediately under normal circumstances. Those triage to green, and literally these colors are attached to patients in humanitarian crises. The green, they'll need medical care at some point when more critical patients with more critical conditions have been treated. And then at the bottom, in black, is the expectant patients for whom survival is not possible. And you can see from the color and from the way this is at the bottom of the pile that these patients have often been abandoned, just pushed aside and allowed to die with no attention whatsoever. So this is a recommended revision, which has now been published by WHO, and it was actually developed by some leaders at WHO and with some adaptations that I've added. The first category is still red. Those patients who, for whom immediate treatment is necessary for survival, but with the addition that palliative care should be integrated with life-sustaining treatment as much as possible. And this applies in less critical situations or situations where there's not a humanitarian crisis, that palliative care should be integrated also into intensive care units. The second category, 2A, is expectant patients. So there's no longer a black category, it's now blue. Survival is not possible given that care is available, but palliative care is essential. There must be provision for palliative care, even for those whose survival is not possible with the available resources. Category 2B is the yellow, of not in danger of immediate death, but treatment is needed soon and palliative care may be needed immediately. And finally, green, will need medical care at some point and palliative care may be needed. So palliative care should be integrated in all of these categories. Another group of patients who are needing palliative care in the setting of public health crises is those who lose access to their life-sustaining treatments because of the crisis. That might be lack of access to cancer therapy or to hemodialysis. Hemodialysis centers may have to close or may not be accessible. So, but palliative care always should be accessible. Here in the next few slides are some ethical principles for optimum care during the COVID epidemic. And these, I developed these as part of an effort to identify these ethical principles for the WHO in their guidance documents on COVID-19. They're not in any particular order of priority. Non-abandonment is the first one listed here. So no person in need of medical care ever should be neglected or abandoned. Palliative care, at least palliative care, always must be accessible. And for patients who are, for whom, who have respiratory failure and for whom mechanical ventilation will not be provided, or when it will be withdrawn, palliative care is absolutely necessary to protect patients from severe dyspnea and any other symptoms they may have. Respect for persons, a person's dignity and human rights must be respected, and their values should be explored and respected to the greatest extent possible. Justice and fairness. Patients with similar health problems and symptoms should receive equal treatment and care, including protective measures, without discrimination based on ethnicity, religion, caste, sex, age, disability, or political affiliation. However, in the pandemic, there should also be fair and just rules for allocation of scarce resources that I'll discuss more in a few moments when I talk about crisis standards of care. Autonomy, people's autonomy should not be restricted except for compelling public health concerns, and any restriction should be minimum necessary to protect health. So the issue of masks and social distancing is very contentious now in American culture, which is a very self-oriented and selfish culture. There are people who are saying it's too much of an encroachment on their autonomy to wear masks. Well, I think it's perfectly acceptable for a government to mandate that masks must be worn to protect especially the most vulnerable from severe illness or death. And of course, the public health requirements should not be excessive, but requiring people to wear masks unless there's some compelling reason that they can't seems to me not excessive. Protection of public health, actually I was just mentioning, appropriate infection control should be in place, respected and enforced. And then confidentiality, all communications between patient and clinician should remain confidential, except in the case of compelling public health concerns. And in that case, only the minimum information necessary to protect public health should be revealed. So this is particularly important in contact tracing, which is so helpful to limit the epidemic. It's a legitimate public health concern to for contacts to be traced, but it's not necessary to reveal from whom the contact might have been or who the contact was who might have potentially infected others. So protect confidentiality as much as possible, but also enable contact tracing. Now the crisis standards of care, and these are standards of care to be applied when the need outstrips the available resources. So here we have an intensive care unit that's completely full. It might even be a regular unit that's been converted into an intensive care unit, as we had to do at my hospital. Normally we have, I guess, about 6 intensive care units, and I think we had to double that number during the surge of COVID. And also emergency rooms tend to fill up and be completely filled. And then there's a lack of, there's not enough ventilators, not enough supplies of various kinds. So it's important to have crisis standards of care in advance, whether they're national, regional, and or institutional, to decide how to most fairly allocate scarce resources in the setting of a crisis like COVID-19. And here again are some principles that are typically, at least in our culture in the US, used in preparing crisis standards of care. One is inclusiveness in preparing them. That is, there should be input from all affected populations. Those who are affected by the crisis standards of care or by the public health problem should have input into the formulation of the crisis standards of care. Transparency, the rules should be easily accessible and understandable at a basic level and available in all major languages in an institution's catchment area or throughout the country, so that it's clear that everybody knows what the rules are. Accountability, there should be a mechanism easily available to challenge a decision and a due process approach to resolving disputes over who gets which life-sustaining treatment or which resource. And the rules should be applied consistently. Very important are the rules of reciprocity and social usefulness during the pandemic. So those who provide essential services, doctors, nurses, other clinicians, also though the food service workers, the sanitation workers, those who clean the hospital, those who clean the streets, those who sell food in the markets or in cafeterias, all those who are essential workers and who take disproportionate risks to help others should have a proportionate return for their contributions, such as priority and access to personal protective equipment, testing and treatment and psychosocial support. And those who are, others who are vulnerable, those with chronic illnesses or disability, those who live in very crowded conditions, the very poor, and those who provide essential services. They may require more protection, personal protective equipment, and psychosocial services. There also should be a mechanism for deciding when there's a disagreement about how to interpret the allocation rules. And ideally, the decision should be made by a committee of volunteer, unbiased, appropriately qualified and respected clinicians who have no personal or professional reasons to advocate for one patient or group over another. That's the ideal. Again, the high risk and vulnerable persons, those living in poverty, homeless people, refugees, those living in very crowded conditions, immunocompromised. In my work in late March, early April, and into May, we created a palliative care COVID team in my hospital that I volunteered for, and it was one patient after another. Older patients in their 70s and 80s and 90s from nursing homes with multiple or with some comorbidity, with chronic illnesses, heart disease, lung disease, liver disease, frailty, one after another. We did not protect this vulnerable population, and it was very disturbing to see. Also, many patients from one of our catchment areas where there are a lot of poor people from Latin America. So high-risk populations, older people, people with chronic conditions, immunocompromised, the poor, healthcare workers, sanitation, housekeeping, and food service workers, and family caregivers. The personal protective equipment that they need, surgical masks, hand sanitizers, surface sanitizers, vaccination, there should be some priority for these groups as soon as vaccination becomes available. And eye protection now is recognized to be very important. And of course, social distancing. The infection control when caring for possibly infected persons or persons who have been demonstrated to be infected, hand hygiene before and after, an N95 or FFP2 mask, a special mask with a seal check. That is to say, the mask needs to fit tightly. So with my very large nose, for example, the normal N95 respirators didn't work for me. The air could get out around the side. So I have to wear a very special N95 respirator for those with big noses. Goggles or face shield, a gown with long sleeves, single use. It has to be either sterilized or disposed of. Gloves, single use, minimize time in the room, and even minimize proximity, which is hard for palliative care clinicians who are used to getting close and remaining near the patient, but we need to protect ourselves. And then using smartphones to keep in contact with patients. Some of the wonderful nurses on our COVID team would keep their headphones on and their smartphones open, have an open line with their sickest patients, so that as soon as the patient moaned or said anything, he or she could respond and help them feel not so alone. The main needs of patients with COVID-19, as like this man, pulmonary care, including ventilatory support and critical care because of respiratory failure, and palliative care. So relief of dyspnea, psychosocial support, and then for family bereavement support. This table I made, it appears in the new atlas of palliative care that's going to be coming out later today from WHPCA and WHO. There's data that shows all of these symptoms listed here occur in COVID-19. The COVID-19 can affect many organs, many parts of the body, and result in quite a number of symptoms. Of course, two of the worst symptoms are dyspnea and so the stress and emotional distress of social isolation. A word about dyspnea and its relief. Opioids relieve not only pain, but also dyspnea. And yes, I know there's a lot of worry and fear that opioids might cause respiratory depression. But when used carefully, according to the guidance that is on this slide and is available in many guidelines, opioid or respiratory suppression is very unlikely. In fact, in my practice, having practiced for 20 some years, I've only seen it a few times, significant respiratory depression, and it's usually due to a mistake. So for example, 100 milligrams is given by mistake instead of 10 milligrams, or with an infusion, a continuous infusion, the concentration of 1 milligram per milliliter is mistaken and accidentally 10 milligrams per milliliter are given. Follow the rules, and significant respiratory, clinically significant respiratory depression is very unlikely. When there is dyspnea and the patient will not be ventilated, or if the patient seems to be having dyspnea on the ventilator, morphine can relieve it. I typically start with half the dose that I usually start with for pain. So be very, very careful, because sometimes a very small dose of morphine can provide adequate relief for dyspnea. So for example, 1 or 2 milligrams IV or 2 to 3 milligrams orally. And for significant dyspnea, I prefer to give it parenterally, give it IV, because it takes effect so much more quickly. If there's no relief after 2 doses, and again, the effect will be seen in 15 minutes. If there's not relief after 15 minutes, if there's no relief at all, either repeat the dose or double it. If the dyspnea is constant, when an effective dose is found, it'll need to be given every 4 hours, or as a continuous infusion, or if a stable dose is found, it can also be given as an oral sustained release preparation if that's available. As I mentioned, COVID-19 can affect many organs, including heart, kidney, brain. It's been found everywhere on autopsy. We see a lot of heart failure related to COVID, a lot of kidney disease, partly because we're also diuresing them, but it's theorized that there's also direct kidney injury from the virus. Delirium is very common, probably multifactorial, and there's a lot of thrombosis, a lot of deep vein thrombosis. If pulmonary edema may be contributing, of course, diurese, but be very careful about protecting those kidneys. And for delirium with agitation, again, try to avoid benzodiazepines, which can make delirium worse. And we, if necessary, if non-pharmacologic interventions such as reorientation aren't effective, haloperidol is a drug of choice. For social support, this slide shows one of our nurses holding her iPhone up so that the family can say goodbye to a patient who's dying from COVID-19 and comorbidities, doing whatever we can to minimize the isolation and the emotional distress associated with isolation. social workers, our social workers and nurses kept in touch with the family to let them know what's going on if they weren't on the smartphone, but use screens as much as possible. And of course, treat for anxiety or depression. Haloperidol is also very useful as an anxiolytic. Benzodiazepines maybe can be used in younger patients, but definitely avoid in older patients. And for patients who have a longer life expectancy, who are going to expected to live for at least weeks and have either anxiety or depression, treat with selective serotonin reuptake inhibitor. Finally, in the last couple of slides, I'll just review again the essential package of palliative care that we developed for the Lancet Commission and then subsequently published in guidance documents from WHO on integrating palliative care into primary health care, into pediatrics, and into responses to humanitarian crises. These are all medicines that are necessary to relieve the standard symptoms that we encounter in palliative care. They're easily usable by people, by doctors, assistant doctors, nurse anesthetists with basic training in palliative care. They're safe, effective, easy to use, and low cost. This is the list. And I put arrows to point out some of the important ones. The most important ones: morphine in oral, immediate release, and injectable formulations. That's the most, probably the most essential of the essential medicines. Haloperidol has many uses, as I mentioned, for agitated delirium, for anxiety, for nausea caused by a metagenic toxin, and then a selective serotonin reuptake inhibitor, whether it be fluoxetine, sertraline, citalopram, or others that might be available for depression and anxiety in patients who may live longer than a week or two. Essential medicines, I'll emphasize the opioid lockbox to help prevent the diversion of opioids for legal use. Nasogastric tubes, pressure-reducing mattress. Because patients often have long stays in the intensive care unit, we're seeing a lot of pressure ulcers, even in younger patients who initially were well nourished. So doing whatever is possible to reduce development of pressure ulcers with pressure-reducing mattresses and turning if possible. Social supports for those living in poverty, very important. Cash payments so people aren't made homeless, food, in-kind support, transportation, funeral costs for the very poor. And then these two documents are very useful. One from the WHO, which appeared in late May, which has a section on palliative care, not a very long section. And then a document that I edited for WHO on integrating palliative care into responses to humanitarian crises. So these are, again, the topics we discussed in the last 30 minutes. Please take care of yourselves, even as you're taking care of others. It's a very stressful time, and there's both physical and emotional risks. We have to take care of ourselves and each other as we take care of patients. Thank you so much.
Thank you, Eric. Thank you very much for an excellent presentation. And we have now 209 participants and 8 esteemed panelists from all over country in various backgrounds. So we will start with the question from the panelists one by one, and Naveen will keep a track from the questions from the participants, and we will try to give all the answers, and afterwards in the last, Professor Guleria, Director AIIMS, will summarize the whole 1 hour what we have discussed and what we are doing in India. So the first panelist, I think
Dr. Eric has to stop screen sharing.
Dr. Eric, you have to stop the screen share,
Yes.
please. So our first panelist is Dr. Rajgopal, probably. Nisha, can you show me the slide, please? Yes. So, Professor Rajgopal, I think, is a pioneer of palliative care in India. Every person who is practicing palliative care is owe everything whatever you have created in India, Dr. Rajgopal. And he is also started his career from Calicut Medical College, where he has developed Pain and Palliative Care Society, which is still working and producing for giving fellowships. Is currently he is founder chairman of Pallium India and Padma Shri awardee. So my question from Dr. Rajgopal is, how has COVID pandemic impacted delivery of palliative care in India, and what strategy you and we have employed to overcome these challenges till now?
Sushma, thank you very much, not only for organizing this session, but also for the very warm introduction. Eric, I'll start from your final message. Your final message was, of course, take care of yourselves. And I remember that because by now, 4 members of our team have been infected by COVID. Possibly 3 of them got it outside the institution, but it's very likely that one of them got from within the institution when we had one patient who was tested positive after death. We are trying, but we need to take better care of ourselves. And the message that you gave just before that is take care of the most vulnerable population. And the most vulnerable population is in countries like India. In the low and middle income world, where primary care is already deficient, we have this issue of creation of more and more palliative care patients, because when in the face of a crisis, primary care drops, insulin doesn't reach people, antihypertensives do not reach people anymore, doctors are not as accessible, blood tests are not accessible, and we in palliative care, if we just sit back and say, we will provide care when you have serious health-related suffering, but we will not prevent it, that would really be an anachronism. So my first message, that something that kept us going, was the realization that a healthcare institution cannot afford to shut down in the face of a health crisis. We must go on, despite all the difficulties. 2, palliative care is not only treatment of serious health-related, illness-related suffering, but also prevention of serious illness-related suffering. And when there is a pandemic, we have to expand our scope of work to prevent the calamity as much as we can. And what we learned from our experience in the last quarter of a century is that this is the kind of situation where we need the community more than ever. When the first lockdown came in March, we found that almost every volunteer who was active was elderly. They could not take part in it anymore. The day after the lockdown, we gave a press release asking for volunteers for between the ages of 20 to 40 with their own automobiles. And would you believe it? In the next 48 hours, we had 90 volunteers. We could engage with only around 50 of them. We gave them online training and they went out. We didn't know what was coming. We didn't know whether we would be able to visit them anymore. We didn't know whether our 5 home visit teams would have to stop. These men, young men mostly, and some young women, took their 2-wheelers or 4-wheelers, delivered medicines for 6 weeks to people who had no access to it at all. And they have continued to help us as couriers. And 2 of them were laboratory technicians. They went around and collected samples whenever that needed to be done. Oh, I shouldn't go on. My time is up. My three main messages is a healthcare institution cannot shut down in the face of a health crisis. It has to expand its activity. Two, we cannot ignore the fact that primary care is deficient. As much as we can, we must prevent serious health-related suffering. And thirdly, engaging the community gives us enormous strength. Thank you very much.
Thank you, Dr. Rajgopal. As usual, for excellent messages you have given. Our next panelist is Professor Lucas. Professor Lucas is because he is in Germany, and we cannot expect. I got confused, and this is midnight, so he has sent his message through video. The answer of this question, that how integration of palliative care in COVID care can be beneficial. Explain. I just wanted to know that how palliative care can be help COVID care. So he has sent his message, and Nisha, can you play the video, please?
And colleagues, thank you very much for the chance to talk about how the integration of palliative care in the COVID pandemic can be beneficial. I am working as a palliative care physician in Germany and have participated in the crisis management teams in 2 hospitals here, but also am working for the International Association for Hospice and Palliative Care, which is much more concerned about the impact on the COVID pandemic in resource-poor countries. So, first of all, what are we talking about? Which patients are we talking about? And I think we have to realize that there are 3 patient groups that basically will benefit from the integration of palliative care. This is first, patients who are not able to access intensive care because of the scarcity of resources in the intensive care area and who are not able to get ventilatory support. They probably will suffer a lot and maybe even die from the corona infection. And relief of breathlessness and other symptoms is paramount in these patients. There is also another large group of patients who will not want to access palliative care, for example, because they already have advanced disease like cancer, or because they are rather old and think they do not want to undergo all the inconveniences of medical treatment in a hospital. And there are patients with moderate COVID infection who probably will not yet require ventilatory support, but still may relief of breathlessness very urgently. The other question is what palliative care can deliver. And I think here 3 main components are really important. One is decision-making and the experience that palliative care physicians and nurses can contribute with difficult decisions in ethically challenging situations. The second is symptom control, come to that in a minute. And the third is social isolation and suffering and how that can be alleviated. Resource allocation and decision-making. I think most countries are thinking about triage systems where the scarce intensive care resources are allocated to those patients who benefit most. But we have to realize that the adaptation of triage for clinical decision-making marks a deterioration of the use of person-centered care in favor of utilitarian thinking. And I think it's important that palliative care physicians, with all their experience they have, contribute to that and to keep at least as much as possible a focus on the patient as a person. This is even more important when you have not only triage of incoming patients, but also have to think about how do you compare patients who are admitted newly to the hospital to those who are already on ventilatory support. These are indeed ethically challenging situations, and I think palliative care can contribute greatly being part of the decision-making teams or the crisis intervention teams or the triage teams. Symptom control. most patients with COVID-19 infection will suffer from dyspnea. A lot of them will have cough, anxiety, delirium, diarrhea, fever, and other problems. And we do not have many studies published from COVID-19 yet, but the information we have and the clinical experience on the ground says that symptom relief in these patients is pretty much the same as in other patients, for example, with breathlessness caused by cancer or lung disease. There are some minor but important differences. For example, you would not use handheld fans because any distribution of aerosols is to be prevented, but rather a cool towel on the face. But you can also use positioning or relaxation therapy. And most important, you can use medications such as opioids, which will be very good in relieving breathlessness. There are international recommendations, same as the ones we have developed here in Germany, saying that opioid-naive patients will benefit from about 20 milligrams slow release or immediate release morphine per day. If patients are pre-treated with opioids, you should start with higher dosages, and that will relieve breathlessness pretty well. Problem is that access to essential medicines is already a problem in many of the resource-poor countries, and I think most regions of India, unfortunately, are in the same position. The Lancet report clearly defined that about 50% of people in the world have access to only 1% of the morphine equivalent distributed globally. That already shows the vast discrepancy and the abyss of access that the Lancet report described. And all three patient groups that I've described before will be in need of opioids. So actually, in the pandemic, the need for opioids will be vastly increased. There will also be competition with other non-COVID palliative care patients who are already on opioid medications and who might find it now much harder to access this. There will be competition with intensive care. Even in high developed countries such as Germany, there has been short periods of problems with access because the intensive care units all stocked up their opioids, and there were problems in accessing, for example, fentanyl or sufentanil for non-intensive care departments. The INCB, the International Narcotic Control Board, has simplified procedures in place so that in the pandemic, governments could order more opioids, but they have to do that. And then still there is a lack of training in healthcare professionals. So physicians and nurses would have to be trained rapidly to prescribe this more basically to the patients who need it. The third area, just to touch it briefly, is the problem with social distancing and quarantine, which means that dying patients may be left alone. They may die alone without their loved ones by their side, without anybody holding their hand, probably not even volunteers or sometimes not even psychosocial workers will be allowed to join them or to visit them. We got even sometimes problems with the chaplains who are not able to access patients because of the quarantine rules. And there may be a restriction on bereavement rights. Even here in Germany, only 10 people could participate in a funeral. And the first patient when I treated, once the pandemic started, and the patient died, and the husband was really sad that he could not even invite people from the village to the funeral. The result is loneliness in the patients, guilt and grief, unrelieved grief in the families and caregivers, and stigmatization of patients who have corona and of their family members sometimes as well. There are solutions to this, and in a short comment to the Lancet, we listed some of them, including using the fast access and the simplified rules by the INCB for import of more opioids, but also, for example, putting in exemptions for dying patients in any social distancing and quarantine rules. This is possible, and even the intensive care people, the intensive care professionals here in Germany told me that if a patient is dying, why shouldn't somebody, the family, be visiting him then? There's always the option of virtual contacts, at least visually and audibly with audio, using smartphones and apps. And I think some patients are already using that. We tried to buy at least a few tablets for those patients who don't have smartphones, so that we could give one to the family and one to the patient, and have them at least have the virtual contact. There are options like virtual visits, prayers, or having virtual tea times together, which is at least a small substitute for the real physical contact. There are other ways of staying connected, like writing letters or paintings or sending photos or favorite music or something like that. And I think palliative care people are quite experienced in finding these alleviations and these management interventions that will make it at least a little bit easier and may alleviate the social suffering, at least to some degree. So I think there's quite a lot that palliative care can contribute, and I do hope that in India as elsewhere, the palliative care community will be able to access the crisis management teams, will be able to be integrated in the response and the management plans. And I do wish you good luck with treating COVID patients and taking care of the pandemic and managing the situations. Being with you, and hope you have a good day. Till then, bye.
Thank you, Dr. Lucas. Our next expert is Professor Dr. Rath, our Chief of Institute Rotary Cancer Hospital and National Cancer Institute. He has not only developed Institute Rotary Cancer Hospital and National Cancer Institute, but he is founder of Cancer Center at multiple places of India. I would like to ask, sir, due to COVID pandemic, there has been some curtailment of cancer services and cancer treatment has been prioritized to those who will benefit the most from cancer treatment. In this context, what do you feel that what should be our strategy, sir?
Thank you. Hello, everybody. During the COVID pandemic, palliative care becomes very, very important to manage not only COVID, but also cancer, two C's. Now, as we all know, cancer is fast becoming #1 killer. Previously, it was cardiac, but with the latest publication, cancer is becoming #1 killer in the most developed countries and the middle income countries. So that has added to the problem. In India particularly, 2/3 of the patients come in very advanced stage, and they are also in need of palliative care. So while we take care of the most vulnerable patient with palliative care, there is a need to have a structured program on palliative care so that everybody is treated adequately. Thank you very much.
Thank you, sir, for the insight that what exactly we should do. Now our next panelist is Professor Padma. Dr. Padma is our neurologist at All India Institute of Medical Sciences, very favorite person of everyone. She is also a Padma Shri awardee. Dr. Padma, I want to ask you, what do you think are the ethical challenges in triaging? Because when we talk about triaging, that we should do triaging, what are the ethical challenges in triaging patients with serious COVID-19 for palliative care treatment?
Thank you, Sushma, for giving me an opportunity to be part of this really momentous conference. I learned a lot. Okay, so in a triage, as far as a neurological emergency is concerned, you have a blocked artery, you need to unblock COVID or non-COVID. So you have a whole lot of emergencies which are now linked to COVID as probably incidental or triggered or causative. So the systems have now very much, there's a clarity of the systems which have been put in place, and it's so well as spoken regarding this by Dr. Eric and even Dr. Lucas, that you need protection of the healthcare workers, so you have that in place, and the protected code stroke and the protected code systems for all the neurological emergencies, the corridors, the green corridors, and having that systems are in there. So your triage And that is so true that a suffering patient, you have a massive infarction. There is coning there. So probably the reflexes are lost, and you know that an intervention is going to be really, really difficult to get him out. Even then, he needs care. So you have to have that system, have a protective gear, have your protocols, and do it. And we've been doing our IVTs, our MTs, and also even the decompressions and also the palliative. And you've been the champion of palliative medicine, so we've taken that. So you have to have that hand holding distinctly with protection in place. Those systems are there. And the second thing, the telestroke or the telemedicine or teleneurology is come up in a big way, even in a stroke unit, in an ICU monitoring that's been talked about even earlier, and also in the primary prevention, as spoken so eloquently by Professor Rajgopal, that you need the preventive measures. And because of lockdown, a whole lot of issues, but now this bug is teaching us new things every single day. And I think even being on a learning curve, we're integrating those things now. So we probably are better off as we now as we were compared to what we were maybe a couple of months ago. So triage is a challenge. However, as so well brought out by Dr. Rick, you have palliative care integrated into every part of a triage system, and that is what needs to be done. And I think thanks to you, Sushma, I think we have been able to do this in our center. So that's what I mean.
Thank you, Dr. Padma. I think we are proud that we are working in a place where, in spite of triaging, not a single patient is deprived of care which is required for the patient. Thank you very much for giving the insight. Our next panelist is Professor Anant Mohan. I think he is an excellent colleague. Since last 7 months, we are working together in one of the COVID Center of All India Institute of Medical Sciences. We are learning with each other so many things, and I'm really enjoying working with him. Dr. Anand, I want to ask you, because you are a pulmonary medicine physician, that breathlessness and respiratory distress is a common problem in serious COVID patients with post-COVID syndrome. Do you think principles of palliative medicine will help in, and how are you managing these issues?
Okay, good morning, ma'am, and thank you. Good morning to everybody. Yes, as regard your question, as you know that the pulmonary system is the predominant system which is affected in this COVID pandemic, and most of the mortality also is directly or indirectly related to the respiratory system and the pneumonia ARDS per se. The most common clinical features remain the cough, fever, myalgia, and dyspnea. And most of them do resolve with time, sometimes very early, but there is a substantial percentage of population who have persistent symptoms. In fact, if we go by a couple of small publications in the last few weeks, one from Italy and one from China, almost more than 50% of the patients had at least one persistent symptom even 2 months after so-called recovery from this pandemic. Even though they may not be very severe, but the commonest ones were persistence of dyspnea and excessive myalgia and weakness and fatigability. So sometimes non-specific, but important nonetheless to the patient. Basically, there is also a physiological, so this was the symptomatic part of it, but there is also a physiological decline actually, and that we have seen by spirometry. A couple of publications on spirometry have shown that even there is a decline in the lung functions also, as evident by spirometry, FEV1, FVC. So there is some impairment in the lung functions as well. Almost 25% of them have some impairment. So these are important issues because we don't know how this will pan out beyond this time. We don't know what it will do in the long term. Radiologically also, almost 2/3 of the people improve, but there is 25 to 30% of the people who have some residual radiological damage persisting. So what will happen to them? The post-COVID phase that you're talking about is also very important. Some of them definitely go on to develop post-COVID fibrosis, and we are seeing more and more of those now admitted with us and coming to us. ARDS is an important part because these are the people who, even when they recover, continue to have substantial symptoms at home. Substantial symptom means persistent dyspnea and the need of long-term home oxygen. So they are the ones who need to be taken care of. How do we take care of them? Your next question was, so when it is mild symptoms, then of course we just follow the principle of general supportive care, maybe give a bit of bronchodilator, the cough syrups and medicines. So most of them recover, multivitamins, and just alleviate their anxiety that it may take some time, but it will go on its own, which it does to some extent. But it is in those patients who require home oxygen therapy, who are substantially disabled at home with dyspnea, they require better care. And in those, we may give inhaled bronchodilators, inhaled steroids for some time. We have tried, though we don't know what works at this point of time. What does probably work will be early institution of respiratory physiotherapy and the other principles of palliative care medicine, early mobilization. This can be done by means of, again, teleconferencing, video conferencing. We can teach them how to do the respiratory physiotherapy at home, breathing exercises, chest physiotherapy. If possible, all these things can be done at home as well. And of course, with a bit of psychological support that, that has to actually start right at the time of discharge from hospital. So these are the things that we are practicing in our place.
Thank you, Dr. Anand. Thank you very much. At this point, I want to apologize that we will overshoot time today, and I think everybody is enjoying as I am enjoying. So we will continue our discussion just 20 minutes or 30 minutes more. So our next panelist is Professor Mr. Srinivas, V. Srinivas. He is from Government of India. He is Additional Secretary in Department of Administrative Reforms and Public Grievance. He is very dear friend of many of us in All India Institute of Medical Sciences faculties. He was our Deputy Director Administration for a long time. Thank you, Mr. Srinivas, for being with us. And I just want to ask you, it's a big question. The primary motto of government is to avoid and limit death in patients with COVID-19. However, there are a subset of serious COVID patients who are elderly with multiple comorbidities and expected to have very poor outcome despite best possible treatment. Should there be a policy to manage these patients differently so that their symptoms are well controlled and quality of life is maximized? Mr. Srinivas, please.
At the outset, let me thank Professor Sushma for inviting me to this webinar. My greetings to Director AIIMS, Professor Guleria, Professor Rath, Professor Padma, Professor Anand Mohan, Professor Rajgopal, Dr. Roli Mathur, and the international faculty, Dr. Eric Krekor, and all the participants on the occasion of Palliative Care and Hospice Day. Palliative care is end-of-life care, and it was rather touching to watch the picture of a nurse holding an iPhone in Dr. Krekor's presentation. To prevent and relieve suffering and to support the best possible quality of life for patients and families. In my long tenure at the All India Institute of Medical Sciences, I have personally witnessed the high quality palliative care provided by Professor Sushma and her team at IRCH, which should be rated as amongst the best in the world. There is little doubt that India currently faces the greatest pandemic challenge since independence, and there is an acute need to formulate palliative care protocols for COVID-19 patients with acute comorbidities who are expected to have poor outcomes. There is a huge unmet demand for palliative care services in our country. Less than 2% of our population has access to palliative care, and there exist significant gaps in palliative care patients, and given the shortages in life support equipment. A guidelines for palliative care for COVID-19 patients should contain networks of palliative care teams across the 3 levels of healthcare, inpatients, outpatients, and home-based care. There is also a need for education and counseling of caregivers and family members as a vital component. And family members need to be informed of the futility of continuing invasive, painful procedures and the ultimate positive outcome in situations where the patient has advanced stage, multiple comorbidities in severe disease. In our country, with enhanced bed capacities, there appears to be that the core objectives of palliative care can be achieved within the existing resources. In cases where reallocation of resources for ventilatory support is necessary, government has been forthcoming with allocations from the PM CARES Fund. It is hoped that the desired objectives can be achieved with these enhanced resource allocations. Further, palliative care protocols need to recognize the dignity in pre-terminal stages and after death. Patients in pre-terminal stages of life should receive the treatment as per protocol. After death also, the protocols for safeguarding of bodies should be well defined with due respect and operationalized. In my interactions with hundreds of district collectors across the nation, I have noticed that several district collectors have visited cremation grounds to ensure that cremations are conducted in an orderly and safe manner with due respect to the departed souls. Given the fact that palliative care in COVID-19 can only be administered from a hospital situation, the determination, resilience, and courage of hospital providers like Professor Sushma is extremely important. And on this occasion, let me conclude by thanking Professor Sushma and her dedicated team of palliative care specialists for organizing this webinar and wish them all success in their challenging endeavors. Thank you very much.
Thank you, Mr. Srinivas, for such an encouraging words. Our next panelist is Dr. Roli Mathur. Dr. Roli Mathur is from Indian Council of Medical Research Bioethics Unit. She is heading the Bioethics Unit, and that is WHO Collaborating Center for Strengthening Ethics in Biomedical and Health Research. Dr. Roli, I want to ask you one thing, that you have been instrumental in bringing out ICMR guidelines on limitations of life-sustaining treatment. What do you feel is its relevance in patients with severe COVID-19 patients prognosticated to have very poor outcome despite all intensive care interventions?
Thank you very much, and greetings from ICMR. And I'm happy to have this opportunity to speak a bit about the ICMR guidelines in the area of end-of-life care. And I thank my previous speakers for beautifully addressing the issues of ethics in the palliative care area. As we all know that end-of-life care decisions present multiple challenges, and for several years, the fundamental barrier has been the lack of clarity in the terminology that is used in end-of-life care. And to overcome this, in the year 2018, ICMR had taken the initiative to develop the definitions of terms which were harmonized as per worldwide consensus and are useful in mitigation of suffering of terminally ill patients. And Dr. Rajgopal chaired the committee that prepared these definitions. It was also seen that there was lack of provisions to guide treating physicians to order do not attempt resuscitation. The concept, even though practiced for many decades in other countries, was not available in India. And in the absence of any laws or regulations, ICMR took the step and came out with a consensus guideline in the month of April this year. Both of these initiatives were planned after undertaking wide consultations with subject experts, palliative care experts, critical care, emergency medicine physicians, neurologists, and of course also the legal experts, ethicists, social scientists, civil society, and public at large. However, the DNR guidelines are very new in India, and the experience at this stage regarding their implementation is very limited. But what is important is to realize the fact that this consensus guideline has, for the first time, suggested a procedure that through an informed discussion and in keeping with the principles of ethics, it can help to guide the patient, surrogate, or family to make choices to forego CPR in a terminal condition in the best interest of the patient. The ICMR consensus guidelines have defined the ethical standards of care, the principles of DNR. They have offered an algorithm and a format for its implementation and answered some frequently asked questions. The guideline is respectful of patients' autonomy and promotes an open dialogue or communication on an extremely sensitive and difficult topic, and it will help to empower patients and families in reducing the ethical dilemma or associated guilt and help to build psychological support. There are further facilitatory provisions such as definitions on who's a surrogate, or when surrogate is not available, how a LAR or a hospital authority can play a role, or suggest how to seek second opinion or go to a clinical ethics committee, inclusion of DNAR in the hospital records, etc. It also discusses the need of further training of physicians, nurses, and staff who are involved in patient care so that hospitals can adopt and implement these guidelines in actual practice. So this ICMR initiative has answered a long felt need, and even in the COVID situation of uncertainties of outcomes and the processes, as recommended by the document, it would ensure that there is transparency and there is compassion for the patient. All of these documents are available on our website. Please visit ICMR Bioethics Unit webpage for the same. And thank you once again for this opportunity to speak on this topic.
Dr. Rowley, thank you very much. You don't know that ICMR guidelines here really has given a strength to working physicians all over the country, that now there are guidelines and they can do something different when patient is at their end of life stage. Our last speaker is Naveen Saleen. Naveen Saleen is a favorite palliative care physician for all over the country, and he know the subject so well that we really love him. Everybody wants to talk to Naveen that what exactly we should do in this area, in this when they are in the trouble. And Naveen is working as a head of the Department of Palliative Medicine. Naveen, I know that you are taking care of patients in your COVID ward at the and providing end of life care for all these patients. Can you discuss the process that you are following and narrate your experience when patients are dying in COVID ward? How are you managing and what are you doing?
Good morning, madam, and thank you so much for the opportunity. I know we have exceeded time. Without taking much time, I will narrate in brief about what we are doing at Manipal. As Dr. Roli Mathur has just mentioned about a very good ICMR plan for limiting life-sustaining treatment in seriously ill patient or critical ill patient or terminally ill patient, where continuing a life-sustaining or initiating a life-sustaining treatment may not have a good clinical outcome. So at Manipal, we have developed a COVID care plan for serious COVID-19 patients. And so how we have developed is we have started by developing a screening tool based upon the widely published literature from Europe and North America. And the screening tool consists of age, frailty score, which is a very important, and we used the clinical frailty score more than 7, comorbidity index, SOFA score, and also we have done a risk stratification for both end-stage organ impairment and in cancer. And once the screening checklist gets completed, usually this is completed by the critical care physician or the medicine staff. We also ask them to complete what is called as a futility document by 2 specialty consultants, the medicine and critical care, because we want to have a very stringent plan so that we have all the checks and balances in place. So once the futility is ascertained, that means that in this seriously ill COVID patient, continuing a life-sustaining treatment or initiating one would not have any clinical outcome. Then we conduct a joint family meeting where the palliative care physician and the medicine or the intensive care physician sits together, answers all the questions, and then we try to know what is the goal of care and try to get a family consent for the documenting the preferences of care, which could also include not for resuscitation and other aspects. And this whole documentation process, including the futility, family meeting, family consenting document, goes to the clinical ethics committee, which acts as the oversight committee and that ratifies the decision. So all these checks and balances will help us through this process. And the palliative care actually starts, or the symptom control measure starts after this one. So this is the process that what we are following. And as I'm speaking today, we have at least provided end-of-life care for 45 seriously ill COVID patients. I'm not telling every one of the families have agreed for a limiting life-sustaining treatment or a palliative care treatment, but I think at least 80 to 90% of them have agreed. And once you communicate them really well and explain to them, most of them do not want their loved ones to suffer more than what they are already suffering. Thank you, madam.
Thank you, Naveen. You have given a very good insight that communication is key of success. So now we will have question answer session after the summary by our director, Professor Randeep Guleria. He is a, I think every day he is working so hard with the the national guidelines and with the nation to fight the COVID-19 fight, and he is very busy. So I think, sir, I'm sorry for overshooting time, but we need your summary nicely what we have told. And I promise all the question answer we will either take it afterwards, or we will definitely, there are hardly any questions I can see in the chat box, all the compliments, but definitely whatever the question answer are, they will be able to ask Professor Eric. So sir, yes.
It was some approving criteria like difficult airway, limited mouth opening, but because of
I think we will take question. Excuse me, we will take question answer afterwards. First, let the director, Professor Randeep Guleria, to summarize the session. Sir, please.
You did not take the chapter of
Thank you very much. I hope you can hear me. First of all, I'd like to really thank Sushma and her team for the excellent program and webinar that she's done on World Hospice and Palliative Care Day. We are all working for comfort care for our patients, especially during the end of life. And this concept is not new in India. History of hospice care started in the 10th century. As far as India is concerned, if you look at the Indian scripts, which suggests that hospice was part of ancient Indian culture. Whereas if you start looking at the modern times, hospice and palliative care is around 50 or years old. And the World Hospice and Palliative Care Day takes place on the second Saturday of October every year, with the aim to share our vision to increase the availability of hospice and palliative care. And this year's theme is My Care, My Comfort. And I think it's very important that a holistic approach be developed when we start looking after our patients. For this holistic approach, we have to be basically involved in reassuring the patient and the caregivers. I think something that we don't do in our busy practice. We have to look at evidence-based approach for control and cure of symptoms and to alleviate suffering. Very often we really don't do that, and that is very, very important. And build a rapport with the patients and relatives. And that can only be done if we have a very good communication strategy as far as patient care is concerned. And I think COVID-19 has really taught us this, that in these challenging times, communication is even more important than ever before. Along with that, there is also palliative care, which includes self-care. And I think this was brought out a lot also by Eric, that there has to be involvement of looking after the healthcare providers. And when we talk of healthcare workers, it's not only doctors and nursing officers, it's all healthcare providers, even the sanitary workers or the others who are involved in healthcare. Very
Sir, your mic is muted, sir.
Very often the healthcare workers who are low down the ladder actually suffer a lot, because they are the ones whom we ignore. And when it comes to providing protective care or looking at their psychosocial support, really no one bothers about it. I wonder how many of us have really bothered about the stress the sanitary worker or our security guards in the hospital are going through when they're looking or screening patients who possibly may have COVID-19, and they probably are not that well protected. So I think these are important challenges that we need to keep in mind. And what COVID-19 has really taught us is what we've been saying for a long time, that palliative care is much more than just looking at care for the patients with cancer. Whether it's acute or chronic life-threatening diseases, palliative care has a very, very important role in that. And this is also brought out by Eric, and we see that every day. Patients who have dyspnea, how do we relieve them? We have patients with interstitial lung disease. They are coming regularly with oxygen therapy. They get dyspneic even going to the toilet. And if you talk to them, their only companion is the oxygen concentrator and the hissing noise that it makes. It's not a good quality of life. And we need to work on improving that quality of life. So improving quality of life of patients and the family members, the caregivers, is something that we need to really address, and we really ignored that. So I think the aim of all of this for all of us should be to prevent and relieve suffering and integrate psychological and spiritual care in our patient care. Unfortunately, modern medicine has a strong bias towards curative medicine, and we have worked only towards that. And this is something which even has come out during COVID-19. We have not integrated palliative care along with active treatment as is essential. And this is something that we need to really work on a strategy that from the very beginning, as we look at treating our patients, how do we integrate palliative care? It doesn't really have to be end of life. It has to be at the very beginning, whether it's breathlessness, whether it's chest discomfort, whether it's other psychosocial stress that the patient has. We have never really done that type of training for our medical students. And I think it's high time that we did that. COVID-19 has really thrown a new challenges for us. The fear of infection, the fear of getting isolated. And this has led to what was mentioned as we should not abandon our patients, the non-abandonment. And this is for not only COVID, but non-COVID care. I think non-COVID care has suffered a lot. And for that, we have really not really worked adequately. We've just abandoned them. And there is something that we need to do as far as this is concerned. And that is also for our healthcare workers, our patients with cancers, patients with comorbidities. They are really not looked after as well as they could have been, and the quality of life has really suffered. We've not focused on palliative care in our ICUs, in our COVID care centers. And there we have just looked at how do we save lives, how do we get them out of COVID-19, wearing our PPEs, wearing all our masks. One fearful of going and seeing these patients. Sometimes there's one doctor and one nurse for a whole ward. And that really is something which causes a lot of loneliness and suffering and fear among these patients. And as was already mentioned, the dignity of death. Very often COVID-19 patients die alone without even the healthcare workers being there, and the last rites are done by strangers. So I think there is a lot that we need to do. And what COVID-19 has also taught us is that we have to innovate. Palliative and care has to become more innovative. Telemedicine, telehealth is something that we have to look at as we move forward in this era of new technology coming in and new normal being set in the post-COVID era. So palliative care, in my mind, is more important today than ever before. And we need to accept the challenges that COVID-19 has posed for quality of life and relieving suffering of these patients, and for those who have already been offered palliative care but have been neglected because of the challenges COVID has thrown. So I would suggest that the entire community of hospice and palliative care should start working together as to how will they provide adequate palliative care in the new normal that we will have in the coming years. I think that is the biggest challenge, and we need to start re-looking at palliative care, keeping that in mind. Thank you very much.
Thank you, sir. Sir, before you leave, there is a question for you that and from Eric, that how much is our country and world? So world, I think Eric can answer. How much is our country is ready to handle non-cancer as well as cancer patients in post-COVID era? Sir, you please answer about India, about how much we are ready.
What you want to know is how are we going to look at palliative care in the post-COVID era for non-cancer patients? Is that what you're?
Yes, sir. Yes, yeah.
So I think the question is that were we looking or providing good palliative care for non-cancer patients even in the pre-COVID era?
Yes.
And then how do we move forward in the post-COVID era? I think even in the pre-COVID era, there was a lot of challenges because palliative care started predominantly from cancer care. But I think we really need to understand that we have patients who have end-stage diseases. It could be lung disease, it could be heart disease, it could be chronic liver disease, patient on dialysis who don't have the opportunity of a kidney transplant. All of these patients need palliative care, and that is something that was not focused, especially in the developing world like India, because the focus was on palliative care only as far as oncology was concerned. COVID, like I said, has taught us that we need to look at palliative care in a broader sense, and we need to bring palliative care in non-oncological practices, and we need to bring it early rather than late, so that we start talking to our patients, communicating with them, understanding that quality of life is more important than just curing or treating the patients. Those are issues that we need to address even in the post-COVID era.
Thank you, sir. I think you are absolutely right that we are not pre-COVID era. Also, we are not doing well with as far as non-cancer is concerned, and we will do well. We will start working on this definitely. Eric, what is the world condition as far as non-cancer is concerned? What exactly? Because we keep feeling guilty that non-cancer patients we are not giving enough attention. But whether the world is giving enough attention to non-cancer patients?
Thank you. Well, you know, I think there's a big difference between the affluent and high income countries and the global poor. In high income countries, the affluent with heart failure and COPD and cirrhosis and neurologic disease, there's palliative care is available for these populations, and there's research on these populations. But in general, the global poor don't have access, even those with cancer don't have access to palliative care. And, you know, I think there's a lot of arguments why palliative care is necessary. It's medically necessary to prevent and relieve suffering. It's ethically, morally necessary. But the argument that I think will be most persuasive to governments to develop policies and to fund palliative care is if there's a financial argument. There's a lot of now data from high and some high middle income countries that palliative care that includes home care, that includes care for patients where most patients are who need it, which is in their homes, that can save money for healthcare systems by preventing readmission to hospital, especially near the end of life, for symptom control, by reducing length of stay in overcrowded hospitals because patients aren't afraid to go home. If data came from India, for example, that palliative care can actually save money for healthcare systems, I think this would be very persuasive and result in further scale up of palliative care in low and middle income countries. I'd just like to add a comment in response to Professor Guleria and also Dr. Naveen, that one of the interventions in my hospital in Boston, which was very much appreciated by colleagues and by patients and families, was that we had members of our palliative care team go to the emergency rooms to, I guess you call it accident and emergency, to help to talk to patients and families in the emergency room, especially the patients who had comorbidities, heart disease, lung disease, liver disease, cancer, and discuss with them their values and the likelihood of benefit versus harm from critical care. And so many patients and families agreed to focus on palliative care in the emergency department and therefore did not get admitted to the ICU. We also had staff in the ICU, especially both to keep patients comfortable while receiving critical care, whether it's mechanical ventilation, ECMO sometimes, but especially when mechanical ventilation was discontinued. So palliative care can have a very important role in the accident and emergency departments and in the ICU and in the community, as Dr. Rajagopal said, for during the COVID pandemic. Thank you.
Thank you, Rick. I think this is again very, very informative, your comment, and I think we have to work a lot. We are extremely behind the schedule. So now almost the questions are over. Only 2 questions which we have to address definitely. Rest all are compliments, so we will not go through it. First, Dr. Rowley has uploaded the link for DNR and all the definitions, so we can see it. Second thing, which Dr. Padma can answer very well, that one doctor from AIIMS Rishikesh is asking whether telemedicine can be a answer for in the era of COVID pandemic. Dr. Padma, are you here?
Well, I could say that telemedicine, or at least screens and telecommunications are so important, as was mentioned by several speakers, for reducing the isolation. You know, there's been various studies, including in India, of telemedicine to reach more people, especially the rural poor. My own view is that there's no substitute for personal contact. So yes, telemedicine maybe can help to reach those who are difficult to reach, but it will never replace the personal contact between a clinician and patient and clinician and family.
Thank you, Rick. Thanks a lot. I think telemedicine is really becoming a very powerful tool in these days. I think this was underutilized tool which we were not knowing, and pandemic has taught us. Thank you very much. And last question, I think Dr. Rajgopal can answer that, whether we have developed home care guidelines in COVID pandemic, whether there are.
Dr. Sushma, and I don't know who asked the question. Thank you for the question. We have not. We certainly have not. I quite see that a guideline like that would be very useful. I also see that it is not going to be easy, because the ground conditions from place to place, from urban to rural, from state to state, are going to be difficult. But I do see that some sort of broad guidelines will be useful. Thank you for the suggestion. We'll, with Sushma's help, I think we can try to create some basic guidelines. Thank you.
Thank you, Dr. Rajgopal. Thanks a lot, and thank you very much. I think we have overshooted almost half an hour, which I never do this, but I was knowing that we will overshoot time, and I don't know how time has gone. 1.5 hours we spent. If someone wants to give, now we have overshooted time, and so if there is any last comments, if someone wants to give, please give. Otherwise, thank you very much, Eric. I know that it must be very late night for you in the now. It must be late night. Thank you, Dr. Raj, for giving your time in the morning. Thank you, Dr. Roli. 7 o'clock in the morning you are here. And Anjum, I can see. Mr. Srinivas, thank you very much. I think such a big representation from Government of India, and the way you spoke, I think we are very, very honored. Thank you, Professor Rath. Thank you, participants. Almost more than 200 participants joined in the morning. Thank you very much. Thank you, Anjum, Naveen, everyone. I'm so happy that we have started World Hospice Palliative Care Day on 10/10/2020. It's such a unique day, 10/10/2020. Thank you very much. Thanks, Dr. Raj. Thanks a lot.
Thank you. Thank you. Bye-bye.
Bye. Bye-bye.